This is my ATTR 810 video on metacognition of my clinical practice. When I think of this particular semester in my clinical practice right now, I kind of tie in three major themes of the class and how they make my patient care a bit more integrative. So we really talked about in-depth risk factors, screening, and clinical prediction roles, and kind of how they all tie together using the disablement model as a framework. When I think about risk factors and how I'm applying them in clinical practice, the first thing I think about is screening tools for the lower extremity, and how if we kind of put in the work now, it will save us the treatment work in the long run. So during our PPE, when I think about our PPE, it's not used for functional screening as of right now. So we have a station-based, and we really focus on general medical conditions and disqualifying conditions. But to me, when I think about the PPE, my mind doesn't automatically jump to screening risk factors for the lower extremity and how that can affect your patient care and how it can affect patient outcomes down the road when we're talking about careers and life after sport. So when I think about risk factors, really the disablement model and the TRIP comes to mind. And while I think I'm using all components of the TRIP model, I didn't actually know that I was using all components of the TRIP model until we kind of dissected what the TRIP model was all about. So when I think about an evaluation, I get the subjective information, I perform special tests, I compare to the gold standards, we treat, we evaluate the effectiveness or assessment. But I don't think I'm thinking about the broader, bigger picture for the whole team. So if I think more large-scale, whole team with the TRIP model, so injury surveillance, which corresponds directly to injury screening, mechanisms, preventative measures, which correlates to our prevention programs that we've talked about this semester, ideal conditions, interventions, and the effectiveness of implementation. I think I'm doing all those things, but at an individual level and not large scale. So if I can use some of these screening tools to identify risk factors of my patients, I can implement them at a large scale and kind of cut down on the amount of injuries or the amount of treatment that I need to do during the season. So obviously risk factors, we've had a direct connection with screening tools like the SCBT and the lower extremity scoring. When I think down the road after volleyball, we really need to be thinking about their career and their life after sport. So how are the altered gait and altered biomechanics going to affect, what implications are they going to have down the road after they've graduated? And I don't think that I think about that in my clinical practice enough. Usually I'm thinking about what are the implications at practice, or what are the implications at school or during next week's game. But obviously taking a step back and really thinking about what about their career, what about their life, we need to take care of the altered gait and biomechanics now, which we wouldn't have known about unless we screened for risk factors. So really it all, to me, ties in very well. And I think I have the best interest of the patient in mind always whenever I'm making a decision about treatment or limitations or accommodations at school. But again, I need to step back and think large scale. What about their career? What about their goals after graduation, to be more integrative? So just like clinical prediction rules, I need to decrease their exposure to radiation for x-rays, and it really makes me think about the secondary causes of whatever I'm prescribing, like an x-ray. And I think I do a good job of explaining to the patient and looking at their patient-rated outcome measures and asking probing questions after they've completed the questionnaire. But I think about communicating the whole body implications to the patient. So even after an ankle sprain, I don't think I am telling my patient, well, if you have altered neuromuscular control, you may have osteoarthritis 10 years down the road, and that may have implications on your job or your career, and that's why we need to take care of X, Y, and Z now. Using some of those interventions and measuring disease-oriented outcomes with some of our screening tools that we've learned about. And obviously that comes down to being better at accurately diagnosing the pathology, so we can be better at identifying those whole body implications. So really, when I take a step back and look at the whole semester and kind of how everything ties in, it really makes me think of those three main things: the clinical prediction rules, the screening tools, and the risk factors. And all of them kind of are intertwined. It makes me think of the Prezi that we did and the video, and how really everything is interconnected, and if you miss one piece of the puzzle, you are missing valuable information that the patient needs and the clinician needs to make the next decision down the road. But really, when I think about my thinking during clinical practice, and if I just think of one word of integrative, the first thing that comes to mind is patient-rated outcome measures. I think I do a good job of taking that information and developing a plan or altering my treatment because, for example, a volleyball player can't wash their hair when taking the quick dash, so we alter their treatment to kind of work on that. But really explaining to the patient what this means from a whole body perspective is really where I need to improve when I think about my thinking.